بسم الله الرحمن الرحيم. كل عيد وانتم طيبين. Today we have a very nice case of a 65-year-old Yemenis patient. Dr. Hind, please tell us the history.
Male patient, 65 years old, complain from palpitation since 8 years, and one attack documented when admitted to the hospital by ECG SVT and received DC shock.
التاكيكارديا كان
على heart rate 180
180 beats per minute, and he received this shock because of his instability. We introduced the casters, the decapolar cast and the CS, and the his. In the his, this is the what did you see in the tachycardia?
Actually, after we introduced the catheters, we started the V pacing, and the V pacing induced tachycardia with simultaneous A and B. Yes.
Okay.
So we started to do entrainment for this tachycardia, and actually we did entrain tachycardia and accelerated tachycardia, and then we had a long PPI.
Yeah.
Okay.
So this is pacing from the right ventricular apex, as you can see here. And he could entrain the tachycardia, and when he measured the PPI was long. So that was the first diagnosis.
Yes.
And then there was another tachycardia.
Yes. Yeah? And then we
can tachycardia. What is seen in here is that the retrograde, whatever the atrial electrogram in the CS catheter is early in the distal CS mesh. So we said maybe this is an accessory pathway. Okay, on the left side, so might have two tachycardia, AVNRT and a concealed left lateral access pathway. So
we tried to entrain the second tachycardia
from the
RV apex, and actually we had a VA dissociation during
this is the confusing point in this was that when we paced the RV right ventricle while the tachycardia was running at faster cycle length, there was VA dissociation, but that was pacing from the right side or prolongation of VA, and the tachycardia continued. صح؟ خش كده. When he stopped, the tachycardia was still there. So there was long VA time when we were pacing from the right ventricle. Okay, but remember this is VAV response. So we thought that this is an atrial tachycardia from the left side. We started by the easiest tachycardia, which is the AVNRT, by ablating slow pathway. يلا ورينا. Still the tachycardia. But we فين بقى الابليشن of AVNRT? We ablated the slow pathway successfully, أحمد الحقيقة. We got very good junctionarism, and we could not induce this tachycardia anymore. But we kept inducing the tachycardia with the earliest atrial electrogram recorded with the distal CS. The distal CS was not actually in the left lateral position. It was in a vein in the posterolateral position of the mitral annulus. Okay? So then we had, Yalla Muhammad. Yeah. So we finished with the easiest one, and we did not demonstrate jump and echo, but the tachycardia kept going. So we ablated slow pathway. Show us the ablation of the slow pathway. This is, yeah. We got Ahmed Al-Hayya. He did a good job. He got very good junctional rhythm with VA time conduction. Very good. Yes, this is the site of the slow pathway. Yeah. Then what is next, Ahmed? Yalla.
So next we had.
Then we kept inducing the other tachycardia.
The second tachycardia was still inducible.
Yeah. So had V pacing بقى.
Okay. And we had the earliest A signal.
Yes, we know that the atrial electrogram, which is in the posterolateral region. I will show you some fluoroba after that.
Okay.
We could entrain this tachycardia. خلاص دي لسه. Now I went to the left side. I said, okay, we finished with the AVNRT, and now I'm going. I was thinking in the beginning that this is an atrial tachycardia, and I have to get an atrial signal before all these A signals. Actually, I succeeded, and I terminated the tachycardia once at a site. I will show you on the fluoro. هات بعد كده.
Okay.
Yes, this is terminated. Yeah.
Yes.
But this is terminated in the atrial port.
Yes.
Could be in the retrograde, could be in the antegrade. we kept inducing this tachycardia without any potentiation with catecholamine. We ablated here, but still we had the tachycardia.
And here we noticed that we have a short VA time.
Yeah, we noticed something that we have very short VA time on the left side annulus, on the mitral annulus. So
you
we decided to
pace from the
left
LV.
ventricle.
Yes.
We said we'll go to the left ventricle. I could not introduce another catheter beside the ablation to the left ventricle, but I placed the ablation into the left ventricle.
First, yes.
Yeah, we did. And
Yes.
then, yeah. This is the tachycardia running. We are trying to ablate, but we could not push بقى على Then we thought if we
Yeah.
pace the left ventricle, we might be close to the whatever tachycardia to get it. So هاد بقى ما حطينا we can see that the VA time is very short here. While we were going into here, we placed the his catheter into the CS into a posterolateral branch, and we did pacing from this side. ما اعرفش انت مسجلها ولا لا؟
Here the pacing will...
اهي
ده
لا that's
اللي في بيسنج من الرباعيه
ما انا عارفه، ما هي من الهيس. جو لا دي بقى خلاص لا. Anyway, we have دي ممكن نجيبها من التسجيل بتاع علي. V pacing from the coronary sinus, the posterolateral branch will give us the VA time very short from the left side compared to pacing from the right side. So I said, okay, this could be one of the rarest accessory pathway which is localized and could be responsible for this VA time very short during LV pacing compared to RV pacing. هات بقى هنا. Then I started mapping. I paced from the left ventricle by the ablation placed in the left ventricle, and I saw Ida very short VA time. This is the clue. This is the clue, the key to this tachycardia. And then
we started to thought about it's AVRT, not an atrial tachycardia.
Yes.
So
because كمان every time we do RV pacing from the right ventricle, you get VAV response. Never we didn't get VAAV response. So the clue was, how about if we pace the left ventricle and map or induce the tachycardia from the left ventricle?
we were able to introduce the quadripolar catheter inside the CS tributary,
Yes.
and we advanced it, and we able to capture LV via the tip of the quadripolar catheter.
Okay.
We get the shortest VA time on distal ablation.
Ablation يلا. Ablation is very. This is. This is pacing from this side. I did pacing also here from the.
We need the yes. This is pacing from the ablation catheter
in the left ventricle.
prior to pacing from LV from the quadripolar catheter. So
You can see very short VA time.
yes,
Then
VA time is totally different from pacing from the RV.
so we decided what to do to advance the CS high up in order to map all these annulus.
Yes.
And we succeeded. Salah ما شاء الله. And then this is the tachycardia running. انت هنا كنا بنبيس during the tachycardia from the left side. The tachycardia
Yes,
running.
yes.
In training.
Yes.
This is in train. Now it is
Now.
in. And VAV response.
Yes, VAV response
V response, that was the key.
with well entrained.
From the left ventricle.
Yes.
And then we got this in the anterolateral part
Yes,
of
I
the-
saw an accessory pathway potential when I said
Yes.
there is a potential between the V and
So
S.
we got here, we ablated here, gave the cardiac termination from the single shot and then reinduction.
Yes.
And then, yeah, mapping, more mapping.
Pages,
Yeah,
go
yeah,
pages,
yeah.
go pages, pages from here. Yeah, pages. Yeah, the artifact of starting ablation here. Go. And termination.
Into the A.
Yeah.
I was on the concealed left lateral access pathway. This is very strange, but keep in mind that the maneuvers helped us to reach this diagnosis.
Continue to see the VA dissociation from the
Then
LV
we
pace.
We kept pacing from the his catheter in
I
the
saw this.
tributary,
Yes.
and there was VA dissociation. Now we are we stayed, we made good waiting period, and that was good. We'll look at the fluorine.
I will introduce the history of this case. He is a 65-year-old male, not known hypertensive or diabetic, with very frequent attacks of palpitation and documented tachycardia at heart rate 190 beat per minute. So we decided to do for him EB study and ablation for the possible mechanism of tachycardia. This is the fluoro. We can see the RO view, the CS catheter inside a CS tributary, and the quadripolar catheter inside the RV, and the ablation catheter at his region. Then we are able to see the his position at LAO view to know the anatomy of these patients.